Thank you for inviting me. I'm going to talk about the gut or GI involvement in scleroderma. If you want to ask questions in the middle, there should be an informal discussion. Happy to answer the questions. So the gut involvement is quite common in people with scleroderma, and I think when we do survey for people with scleroderma, we find 90 to 95% of the patients will have some GI involvement, and it has a big and a major impact on your quality of life. I've already talked to a few of you who talk about the difficulty with eating, heartburn, and other aspects of it. So the goal here is to talk about what are the gut involvement and how to manage them, and who do you see if the symptoms continue to happen or progress. But the thinking, why do people with scleroderma get gut involvement? There's an autoimmune hypothesis, meaning that your autoimmune disease can develop certain antibodies. Some of you have anti-topoisomerase or scleroderma 70 antibodies. Some of you have centromere antibody. Some of you have RNA polymerase 3 antibody. But there are certain other antibodies that are associated with significant GI involvement. But most of us think that because of the cuffing, the collagen that you have under your skin in your lungs is also cuffing the nerve cells of the gut, can then slowly destroy those cells and can decrease the motility of the gut. Everything that goes wrong in scleroderma goes because of decreased or dysfunctional motility. So the motility slows down over time. You're talking about the motility of the food pipe, stomach, lower bowel, and the rectum. So as I talk about it, if not all, majority of the symptoms are due to decreased motility of the gut. So let's ask questions. So this is a GI tract. It starts from mouth and goes all the way to rectum. And you can see we start with the oral cavity. We have the food pipe, which the doctors, or we in medical term call esophagus. We have the liver, we have the stomach, we have the small bowel, large bowel, rectum, and anus. So a question for everybody, is the liver on the right or the left side? Who said right? Oh my goodness. Are you sure? Okay, good. Okay, so we got that part clear, yeah. So, you have your liver on the right side and the spleen on the left, so we will talk a little bit more. So most of us do not talk about the mouth involvement, what we call oropharyngeal manifestation. About 20 to 30% of you have dry mouth syndrome, right? And that can be quite disabling, have difficulty chewing food, saliva production, and what we call Sika syndrome or Sjogren syndrome. To be honest, right now, there's not a lot we can help you with. There are many trials that are happening. I was in a meeting at Novartis, and they are doing quite a bit of trials for primary Sjogren syndrome. So looks like drugs similar to rituximab and others are being tried for Sjogren syndrome. But right now, what I can offer you is the most important thing probably is seeing a dentist 3 times a year. Now, I know most of the insurances only pay for twice a year, but it's very important to get regular dental cleaning. Trying to use sugar-free gum, if you can find sugar-free gum, trying to increase the saliva. And the other things are, these are the 3 things that were shared by Dr. Leder. David Leder, some of you may know him. He's a dentist at Tufts University. And these are the things that he has advised me, and I tell my patients all the time. Xylee melts, again, these are sugar-free melts that you can put in your mouth if you're going out somewhere, so there's saliva, artificial saliva production. There's a supersaturated calcium phosphate. You can use it at night, and it can promote saliva production, but it also strengthens your teeth. And then you have fluoride-based products that are shown out here. All the things that I'm showing you out here are available without prescription on Amazon.com. So if you feel like going there and buying it, you're more than welcome to do it. And then the adaptive devices. If there's one investment you should make, all of us, is to buy an electric toothbrush. I think that's probably the most important take-home message I can give everybody. There are adaptive devices for floss that you can utilize in your practice or at home, and the other things that your dentist would tell you. But find a good dentist that would be willing to clean your teeth 3 times a year. Most of you should get fluoride treatment. I know the insurance doesn't cover fluoride treatment, but most of you should get fluoride treatment. Your dentist would always ask you, do you want a fluoride treatment right after dental clinic? And most of us say, no, we don't want to pay the $30 extra to get that fluoride treatment. But in your case, because of the dry mouth, it will promote enamel destruction. And here's a patient. You can see that this patient in the back of the teeth has quite a bit of enamel destruction. You can look here. So you can look here, there's quite a bit of enamel destruction in the back of the teeth. And this is because this patient has ongoing gastroesophageal reflux disease. What it means in English is they're having a lot of heartburn and acid reflux. And they're not aware of that, but when you look at their mouth, you see quite a bit of dental destruction from the acid that at night maybe they're sleeping at an angle or they're sleeping on their back, and the acid is affecting the teeth out there. So if you get recurrent cavities, you're getting recurrent cavities, most of the time we think about dry mouth. So that's why the fluoride treatment and the calcium products are important. But if it's in the back of the teeth, especially while you're sleeping, your dentist may advise you to see a gastroenterologist to look for whether you're having silent aspiration or acid reflux at night. I hope none of you are having, but these are telltale signs for us to show that you may have uncontrolled acid reflux. So the most common symptom a person with scleroderma comes with is the heartburn, right? Almost all of you have heartburn associated with scleroderma, and it is caused by dysmotility. Dysmotility is a medical term meaning that the motility is decreased and it is dysfunctional. And if I show you a manometry, this is called a manometry for a person who does not have scleroderma. So we'll go over this, what it shows here, and the thing is not working here, so I'll walk you. The first part is the upper part of the swallowing, what is called UES. And then you have muscles that you have control over. When you swallow, if it doesn't go in the right tract, you can cough it off. So those are the muscles we all have control over, what we call striated muscles. And then you have smooth muscles where you have no control over the food. Once the food goes beyond your hair, there's no way to bring it up, unless until you put your fingers and try to do that. But the food is going down or getting stuck out there. So here's a person without scleroderma who has asked me to swallow, make a swallow, and there's a pressure that you see what happens when you swallow something. There's increased pressure to push the food down. And then here's a patient of mine with scleroderma. And you can see there's absolutely no pressure happening after the upper part. There's a normal pressure, but go down the slope, there's hardly any pressure being elicited when they're drinking a cup of water or orange juice. So this is what happens in long-term scleroderma. There's a dysmotility of the gut, and really it is very, very hard for you to be able to control, you to be able to manage that part of the disease. Now the symptoms that you see, we talk about heartburn as a predominant symptom. Does everybody know what a heartburn is? I think all of us have gone through heartburn one way or the other with pizzas, with ice creams, or whatever it may be. The other symptoms of reflux may be difficulty in swallowing. So, you say, my food is getting stuck out here. Chest pain. Some of you, unfortunately, have gone to ER. You were having severe chest pain, sternal, and you went to the ER and they looked for cardiac enzymes, said everything was normal, and then you were found to have significant heartburn or reflux. I showed you the person with mouth ulcers and burning. A lot of patients come to me and their voice is softer, and I ask them, what happened? Your voice is soft. Because at night the acid is irritating their vocal cords and they don't know. And what we call change in voice. So if you start to notice a change in voice, you're probably at night the acid is irritating your vocal cords. You're waking up at night, especially at night with cough. You're waking up every night and you're coughing and coughing and coughing. That means we will hear a talk on lung fibrosis after this. Maybe the acid is, that's called silent aspiration going into your lungs and irritating and eliciting a cough reflux. And there are cases where people develop new onset asthma that may be also be associated with that. So once you have esophagus or a food pipe that looks like this, there's really no medication I can give to increase the motility of it, because the lower part of the food pipe is not working anymore. The nerve endings have died or dying, whatever you want to put it. There's no way to redo the circuit of the gut. It's a very intricate system. I cannot rebuild. Nobody can rebuild that system. So unfortunately, the damage that has happened, and there's no medication out here that will put the wires together into the circuit and start the esophagus from moving again. So the best thing you can do is to sleep at an angle. I hope all of you sleep at an angle. If you don't, you should be. And that's the end of my talk. If you have to take one take-home message, you should be sleeping at an angle. You should buy wedge. The wedges that I've shown on the left upper, you can buy everything from Amazon. And you should only buy 2 wedges. I have patients, I'm not kidding, when I ask them to raise their bed, they raise the whole bed. So I feel obligated to tell you that you're only supposed to raise the head side of the bed. You can buy the wedge pillow, but remember, don't get too dramatic, because there are wedge pillows that are at a very steep angle and nobody tends to use it. So you need about a 20 to 30 degree angle that you can do. Don't use the pillows, because people tend to use pillows and then they increase the pressure in the abdomen, and that's not good. And most of the time, the pillows are on your face by the time you wake up in the morning. So don't try to use pillows to kind of raise your heads. And if you can afford, there are now electric beds that you can buy. There's an ad that comes off that basketball player and his wife, I'm forgetting their name, but so if you can afford that, that would be also a good investment to make. Now the treatment is, what treatment do doctors give you? A proton pump inhibitor, right? Omeprazole, Prevacid, Nexium, Protonix, there are many, many of them. You should take that proton pump inhibitor about 30 to 60 minutes before meal. And it has an interaction with your mycophenolate. So we'll talk about, it reduces the efficacy or effectiveness of mycophenolate or Cellcept, the medication that you take. So we will talk about that. Usually we start a proton pump inhibitor once a day in the morning, wait for about 2 weeks, see how your symptoms have improved or not. Most of the people do really well with proton pump inhibitor. University of Michigan pioneered the surgery for the food pipe in 30, 40 years ago when the proton pump inhibitors were not there. I've been at Michigan for 13 years now. I think I've sent one patient for that surgery, esophageal surgery. So the proton pump inhibitors really, really work if you take them properly and appropriately. If the symptoms are still continuing, you can increase it to twice a day, but if the symptoms are still there, then we refer you to a GI, a gastroenterologist, to get a scope done to make sure there's no stricture and to rule out things like candida. So if you look at the pictures, the top pictures, you see the whitish lining, that is a fungal infection called candidiasis, and that may be causing these symptoms because of the dryness and dysmotility that is happening. If you still continue to have reflux symptoms, despite taking proton pump inhibitors, most of the time it is non-compliance. Most of the time it is that people say that, I have read a lot of bad things about proton pump inhibitor, and we'll talk about this, and I only take it when I get symptoms. So I don't take it every day religiously, but if I don't have symptoms, I don't take proton pump inhibitors. Some people have non-acidic reflux, which is listed down below there, which means that the acid that is coming out or the reflux that is coming out is not acidic. Proton pump inhibitors only work for acidic reflux. It neutralizes it. So that's why the best treatment for reflux is sleeping at an angle. Of course, not waiting for 3 hours before you get to go to bed, taking 3-4 small meals during the day, not eating pizza at 10 p.m. of night, all those goes without saying. But the best thing you can do is not to eat 3 hours before you go to bed and, sleeping at an angle. So the challenge with proton pump inhibitor recently has been there's a lot of long-term negative side effects that have been published. And some of them are listed here: dementia, osteoporosis, certain kind of atypical infections and pneumonia, poor absorption of calcium, magnesium, B12, depression, and cardiovascular death. And here's a prescribing information from, I think, one of the proton pump inhibitors that I copied, and it says PPI may be associated with C. diff, which is a weird kind of GI infection, bone fracture, and low magnesium. So this is a FDA document highlighting the adverse events of this thing. So what is a patient supposed to do with scleroderma? If you look at the package insert, the prescription insert, all of them should be given not beyond 8 weeks. If you look at anything, proton pump inhibitors should not be given beyond 8 weeks because of the side effects. But people with scleroderma is an exception, because the day you stop proton pump inhibitors, and many of you have tried to do it, what happens? The acid comes raging back. So you need to be aware of these parts, and you should be working with your rheumatologist to make sure they do your bone density scan on a regular basis. And if you never had a bone density scan, all of you should go and get a bone density scan to make sure your bone density scan. You should make sure that your calcium, magnesium, B12 levels are appropriate. You don't need to do it every year, but just get a baseline check now to make to confirm those. And then the other part of it is to get the appropriate vaccinations that are appropriate in your case.
Is there the cardiovascular death as a risk also? How frequently?
Yeah, thank you for asking the question about cardiovascular. So all these studies have been done using what we call administrative databases from Kaiser and others. So they have, Kaiser Permanente has 1 million people. And they are doing the studies. They look at 1 million people, not with scleroderma, millions of people, and they look at people who have been taking proton pump inhibitor for many, many years versus those who were not taking it. And they're just for age and the other diseases, and they say, despite adjusting all these things that we are seeing. None of these have been seen in scleroderma people, because you will need hundreds of thousands of people to be able to show clinically meaningful or statistical difference. So I don't know about exactly, but these are the things that are associated. Association in medical terminology is different than this is the only thing that is causing it. Because people who are, for example, taking proton pump inhibitors may be older, may have higher cholesterol, may be eating not so healthy stuff. So there are different things that may be promoting that. But what the FDA is saying is that there indeed is a risk. And I don't have other choices for people with scleroderma. If you're having a heartburn, you're having a heartburn. If your heartburn is very well controlled and you're taking a proton pump inhibitor, you may want to take Tagamet or Pepcid and give that a try. But if you're getting symptoms, I'm pretty sure you're aspirating at night, and that's not a good idea, because there's some data to suggest that aspiration can cause lung fibrosis or worsen lung fibrosis. And that's not what we want to do. Any other questions on this part?
I have heard that PPIs could be the cause of something called a cardiac polyp in your esophagus. I'm wondering if that's...
What kind of esophagus? I didn't hear you.
I had heard that PPIs could cause something called a cardiac polyp in your esophagus. I wondered if there was any danger in that removing it immediately, or what could happen.
I think you said polyp, right? Cardiac polyp. So acid is important. There's a reason stomach has acid. The acid is important to kill the bacteria and viruses, and to help promote digestion and help promote absorb these calcium, vitamins, and magnesium that I'm showing. So yes, I mean, long-term use of PPIs can also promote polyps and other aspects of it. And again, if you are not improving, the only way to diagnose them would be to do a upper GI endoscopy and to look for those.
So is it dangerous if you don't remove it right away, or?
Well, polyps can turn cancerous, like in the lower gut. So there are no recommendations from the American College of Gastroenterologists to do regular endoscopies, unlike what we do for colonoscopy. Polyps usually are slowly growing, majority of them. There might be exceptions, but they're slowly growing polyps. And most of the people, if you're developing polyps, you may not have any symptoms at all, but you may have uncontrolled heartburn and other aspects that would lead a gastroenterologist to do an endoscopy in you and to make a diagnosis. The other thing I wanted to highlight is that the mycophenolate, a lot of you take mycophenolate and proton pump inhibitors. Mycophenolate requires acidic environment to convert to active drug. Both proton pump inhibitors and even the Tagamet Pepsid you take can reduce the bioavailability. It interacts. Because it reduces acid, it decreases the availability of the active form of CellCept. So what I tell my people is patients to take proton pump inhibitor in the morning. So you take it in the morning, and then you can take mycophenolate in the afternoon and in the evening, because most of you take 2 doses of it. So that's one suggestion. Let the proton pump inhibitor do its job in the morning, and then you take your mycophenolate in the afternoon and in the evening. Yeah, I think if you follow everything to T, what's prescribed, you will never eat. Yeah. Yeah, this is what, because we want people to take antacid in the morning, the first thing in the morning. So most of the people take it in the morning, and then they take their mycophenolate, synthyroid, and other medications in the afternoon or in the evening. Or you can take your proton pump inhibitor in the afternoon if you want. Well, yeah. So that's also. It doesn't have to be exactly every 12 hours. That's what I'm saying. I mean, you can take at noon and 7 p.m. This 12-hour. I mean, there's no magic when we say every 12 hours. We want you to take twice a day. There are patients of mine which take 3 grams of mycophenolate at one time, because they can't remember, and that's absolutely fine. It seems like that looks like you wake up at 4 a.m. by the time. Yes. Oh, mycophenolate, a lot of people can tell you, I'm sure 90% of the patients, it's an immunosuppressive therapy that we give to people who have skin fibrosis and mainly lung fibrosis. So it's an anti-inflammatory immunosuppressive therapy. Now, if you are not able to tolerate and you still continue to have symptoms, there was a study done with this drug called Gaviscon. It is not available here, but everything is available on Amazon, like I said. And it's called alliginic acid, and the way it works is it forms a barrier over the stomach. So you take it, I think, 2 or 3 times a day, and it forms a barrier, a coating over the stomach. So it's very effective in reducing the symptoms of acid reflux and heartburn. It is pretty expensive, but it's available, Gaviscon. If you go to Amazon.com, it is available there 3 times a day. See, I'm an advertisement for Amazon out today.
You got a few shares?
No, I don't. I should.
Why isn't it sold in drugstores?
Say it again?
Why isn't it sold in drugstores?
Oh, because it's not FDA approved. So a lot of treatments that we do in scleroderma are not FDA approved, and to be available in drugstores,
Not FDA approved for scleroderma.
or FDA approved at all in US. So I think it is approved in Canada. You know, some medications like domperidone and others are not approved in this country too. So it depends. So I'm going to go into something that all of us worry about. It's called Barrett's esophagus, which is really a precancerous lesion. So if you continue to have significant acid reflux, there are patients who come to me and they say, I'm not going to take a proton pump inhibitor because I don't want to get dementia, I don't want to get fractures, I'm going to live with this heartburn. I think it's easier said than done. If you are having heartburn on a regular basis, I don't think anybody can live like that. I mean, it is quite disabling, but there are some people who want to do that. But you're putting yourself at risk of A, aspirating at night, and that acid going into your lungs. B, certain parts of the lower part of the food pipe or esophagus turning into a cancerous lesion. And Barrett's means that it's a precancerous lesion that can develop into an adenocarcinoma of scleroderma. Dr. Mays did a study where she did endoscopies and showed that 13% of patients who had symptoms despite taking proton pump inhibitor had this. So the key thing is that what I'm not trying to scare you, I'm trying to say that you need to be aware of it, number one. And if you continue to have symptoms despite taking proton pump inhibitor, you should be seeing a gastroenterologist and getting a scope done. Because a lot of things can be seen on a scope that you otherwise cannot do. Any questions?
If someone does have Barrett's, do you see any patients that go back to a normal biopsy?
No. So once you have Barrett's, once you have what we call dysplasia, most of the people stay with this dysplasia for a while, but you get regular endoscopies. So it's similar to colonoscopy. If they find polyps, then they bring you every 1 to 2 years, depending upon how severe it is. So they might keep a very close eye on you and do regular endoscopy and do multiple biopsies to make sure that it is not transitioning into something more abnormal. And you will hear about ILD, but you know, here's a patient, and you know, there are a lot of studies talking about aspiration, silent aspiration going into the lungs, and people have argued that that may be the cause of ILD. But definitely we have seen people who come and who have worsening of lung fibrosis happening because they have been aspirating quite a bit, and there are signs that you'll hear next talk that are associated with interstitial lung disease and asthma. So the take-home message is sleep at an angle. If you're still having symptoms, see a gastroenterologist and get an endoscopy. So we are moving from the food pipe and going into the stomach now. So stomach, again, dysmotility, slowing of the gut because of the fibrosis of the intricate nervous system that you have in your gut. That intricate nervous system is slowly dying. So as it's slowly dying, the circuit is, is getting short. The gut is slowing and the stomach is slowing. So the food you eat, the water you drink, goes from your food pipe into your stomach. And it is sitting in your stomach, and the stomach is supposed to push it into the small bowel. So if it doesn't do that, what happens? You start to feel bloated. You don't get hungry because the food is sitting in your stomach. So that's what you start to see: nausea, vomiting. Early satiety means that you get full. You have a couple of bites of food and you say, I'm full. You're not getting very hungry, and as a reason, you start to lose weight because of that. So the best way to deal with that, and the most common cause of gastroparesis is diabetes. So in diabetes, people get small nerve neuropathy or nerve involvement, and that's the most common cause because diabetes is so common in the United States. The treatment, if you're feeling bloated like this, the key thing is to see a nutritionist, work with a nutritionist so that you're getting enough protein and vitamins and things like that, and take small meals throughout the day. That's probably a good advice if you don't get full, or if you get full very quickly and don't have a good appetite, to make sure you're taking enough food. And if you still have symptoms, you see a GI doctor or do a gastric emptying study. Has anybody ever had a gastric emptying study? Wow. So gastric emptying, so some of you can tell me that they give you peanut butter and jelly sandwich that is radio labeled. Not radioactive, radio-labeled. I just want to clarify that. This is a person who has normal gastric emptying, so they took the food at time 0, and it went into the stomach in 15 minutes. I mean, you can see how quickly the food gets into your stomach. And by the 75, 90 minutes, the food is gone. So the food went in 90 minutes, and that's why sometimes people get hungry every 2-3 hours, because the food that was in stomach is gone to into the small bowel. This patient had a half jelly sandwich with 4 ounces of apple juice. So it says down there. In people with scleroderma, the food may sit there, I have seen, for 4, 8, 12 hours. So the food may just sit there because of the circuit that is not working well. There are medications that are available. All of them, if not majority, if not all, have a black box warning. Now, black box warning is given by FDA when medications can have significant side effects. And the side effect of all these medications are related to your cardiac conduction and rhythm. So you should be getting an EKG before any physician gives you these medications. They are metoclopramide, erythromycin, domperidone, and cisapride that is not available in US, but is available in Canada. Has any of you tried this medication? Which one are you taking?
I'm not taking it now, but I tried the metoclopramide.
Did it work? Kind of.
Yes, but I couldn't tolerate it.
Yeah. What about you?
The domperidone.
Are you still taking it?
Yes.
Does it work?
Not as much as it used to.
Yeah.
I think, but it's also hard to tell because my system works differently every month. So
Yeah.
it's hard to tell.
So I think that's an important statement you made, because by giving these medications, we are not doing anything to the circuit. The circuit is getting short all the time, the nerve root. So you'd expect these medications to lose their effectiveness over time, because as the circuit gets destroyed, the muscles get atrophied, the motility gets worsened, so you would expect this to be. Reglan or metoclopramide was the one that we used to use a lot, but it can cause significant depression and it can cause tremors and other side effects, pretty bad side effects, so we tend not to use it. Domperidone is not approved in US. It can be obtained from Canada or Mexico. It is not approved. But if you do use that, make sure your doctor does a EKG, because it can cause widening of the electrical, or slowing of the electrical circuit of your heart. And then there's something unusual that is common in scleroderma, which is the telangiectasias of the gut, of the stomach. You all know what telangiectasias is, the dilated blood vessels you have. So this is called watermelon stomach. Does it look like watermelon? Yeah. So this is a patient of mine from UCLA who has significant watermelon stomach, and it is seen in about 10% of patients. And people come to you, the classical presentation is person comes to you, they say, we are tired, we are fatigued, we do your hemoglobin. Just because you are there, we are doing it, and you have significant low hemoglobin with iron deficiency anemia. You have been having intermittent bleeding, and you're slowly bleeding, and that's why you're getting tired, fatigued, and it's usually in early scleroderma, early diffuse scleroderma. Anybody has gone through this? So as you can see, a lot of people had heartburn, but as we are going down the gut, the number of symptoms and everything, fortunately goes down. So it looks like this, and your gastroenterologist goes in there and starts to freeze these areas. And you may need 1 sitting, you may need 10 sittings. It depends how severe is your watermelon stomach. So most of you hopefully will never have it, but if you have significant iron deficiency anemia, low iron, despite having adequate diet, this may be the reason. You should be seeing somebody who is experienced, because most of the GI people, now this is classical case, that's why I'm showing you, but it's not this classical most of the time, and most of the GI people, even after doing endoscopy, they can't tell it, and when I look at the photographs, I can tell that this person has gastric enteral vascular ectasia or watermelon stomach. Before I go to the bacterial overgrowth, I want to talk a little bit about fibromyalgia of the gut. So this is similar to they come to us with scleroderma and everything seems to be okay, but they have distension, bloating, diarrhea all the time, and we really can't find what is going on. In those people, trial of antidepressant medications like Buspar and others seems to be very effective. So if you continue to have, it's like irritable bowel syndrome, but you technically don't have irritable bowel syndrome because you have scleroderma. But this is a fibromyalgia of the gut, and using medications such as Buspar and the other medications seem to be effective. So just remember, if you continue to have symptoms again and again despite taking all these medications, something to talk about in medical term, which we call visceral hypersensitivity, that your gut is hypersensitive or it's fibromyalgia-like. Okay, so moving down to the small bowel now. This is probably the most common cause of weight loss apart from depression in people with scleroderma. And you have to think about, we have a small bowel where all the nutrients are extracted from the food. So all the chips that you eat, Doritos today, that's okay. There are no nutrients there, so you can eat them. But everything else we ate today, all the nutrients are being extracted there. There are bacteria that live in our large bowel, what we call microbiota. They are very diverse. In scleroderma, because of the dysmotility of the gut, those bacteria come from the large bowel into the small bowel. And they start to compete with your food. So the symptoms that will happen is you eat, you're bloated. You're bloated, you're losing weight. The stool are very smelly, what we call, you might have diarrhea with pale, greasy, foul-smelling stool. You see fat in the toilet. You see the fat globules in the toilet. That tells you that there's malabsorption. The gut is not absorbing appropriate food. And because you're not absorbing vitamins and nutrients, you start to lose weight. So you start to a lot of diarrhea, a lot of bloating, distension, loss of food, lack of appetite. So inability to gain weight, distension, bloating, and then you might develop something like, I'm not talking much about pseudo-obstruction. Has anybody here had pseudo-obstruction? One, okay. So pseudo-obstruction is that your gut has said that I had enough, I don't want to work. Do whatever you want to do, I'm not moving. So the gut wants to take rest, right? And it's very important to know, the reason I bring it up, if that ever happens and you go to the ER, because if your gut is not working and you're throwing and vomiting, where would you go? You'll go to the ER. And the surgeon will come and say, okay, let's take you to the OR, cut you out and see why it is obstructed. And most of the time, the treatment, if you have scleroderma, is you need to tell them, I have scleroderma, I might have pseudo-obstruction. That means not a real obstruction. The gut is tired and it is taking a rest. They start you on IV antibiotics, fluids, and in about 3 to 5 days, the gut starts to move again slowly. So the last thing you want is to do is a surgeon opening you up and taking out the part of your bowel. The treatment for pseudo-obstruction or bacterial overgrowth is long-term antibiotics. So I'm sure you take long-term antibiotics or chronic antibiotics. Anybody else takes chronic antibiotics for malabsorption? That is good. So the treatment is rotating antibiotics. We rotate through antibiotics because there's, again, nothing I can do to speed up the motility of the gut. The bacteria are residing in your small bowel. They are competing with your food. I can give a course of antibiotic to kill those bacteria and flush them out, decrease the quantity of the bacteria. The patients really feel good, and after about a week, 2 weeks, a month, the symptoms come back because the bacteria start replicating again. There's nothing I can pump out to take flush out the bacteria. There's nothing I can do about it. There are certain medications our gastroenterologists use, but fortunately none of you or most of you don't have it, but we cycle between them so patients do not develop significant resistance to these antibiotics.
Do you believe in just taking, instead of cycling, just taking Xifaxan, maybe not every day, but like on a rotation, say like every 3 or 4 days or once a week?
Yeah, Xifaxan or rifaximin is a medication. It's an interesting antibiotic. It is only restricted to your gut. It is not absorbed in your blood, so it doesn't have any other side effects that are associated. It's approved for irritable bowel syndrome. I'm not sure how to answer that question, taking it on as needed basis. You have been prescribed because, do you take it?
I do.
For what?
IBS.
IBS. Yeah, I mean, for irritable bowel syndrome, I think the work that has been done, it's a time limited
Well,
prescription.
They start you out on, like, you take like 3 a day for 10 days, but then if you can get rid of, hopefully, the SIBO, or the IBS tempers a little bit, then you can start to
Taper it down.
a little bit. Like now, I still take it though every 3 days.
And if you don't take it every 3 days, the symptoms come back. Yeah. So you probably have a hint of SIBO that is going on, because by definition you probably don't have IBS because you have scleroderma gut. So what is telling me, that is fine. It seems telling me is that a better way today would be to take another course for 10, 14 days and then see how long does the effect last. That's probably a better way to do it rather than having symptoms again, taking it 1 or 2 doses every 3 days. That's what I would recommend.
Thank you.
And then we come to the fun part, constipation. So there are 2 kinds of constipation, believe it or not, the regular one and the scleroderma one. So one is called a slow transient constipation and one is a normal transient constipation. A normal transient means that your gut is functioning fine, but the gut is not slowed because of the scleroderma. The gut is functioning, but because of lack of bulking food or whatever it may be, you have constipation. And you can diagnose that by doing SITS markers. So you see those dots. So we have you swallow, I think, 25 or so of these pellets. These are radiopaque that goes out. And we do x-rays every day for, I think the radiologists do it for 3 days. And they should be all flushed out, or most of them, like you see on the right side. But on the left side, there's a scleroderma patient where all those things are still there. Why is it important to know whether you have normal transient and the slow transient? Because the treatment may be different. If you have a normal transient, then we will give you high fiber diet, bulk forming laxatives, Colace and Metamucil and things like that to improve the stool formation and defecation. But if you have a slow transit, these therapies will make it worse because it will add the volume to your stool, but the gut is not moving. So you will cause impaction and cause a lot more trouble and issues with you. We tend to do it occasionally, but we have started to do a lot more because there are medications that are available now for management of idiopathic constipation that are listed out here. So Linez is one of them. Some of you might have tried it, but there are medications now that a gastroenterologist can use if you have a slow transient constipation to push the food out and to stimulate the gut from functioning fast. And indeed, there was a clinical trial that was done in Italy where they gave people with chronic constipation and it's scleroderma patients, 40 patients, and they showed, oops, what did I do? I did something here. Let's try it again. But they gave it to people, 40 people, and they did show that the people really improved, the symptoms really improved, and the bowel function improved. Did it come? No. Okay, so last part of the talk, talking about the rectum, people don't talk about fecal incontinence. I must tell you that's very common. There's a GI questionnaire that I developed at UCLA called UCLA GI. I'll show you 1/3 of my patients always have some degree of fecal incontinence. And most of the doctors don't want to talk about it, and most of the patients don't bring it to our attention. And that is part of it is because there are 2 sphincters. One is an external sphincter, which you have control over, and internal sphincter, which you don't have control over. But there's scarring and fibrosis of that leads to weakening of your rectal muscle and strength. So the treatment could be, you might see a colorectal surgeon, a gastroenterologist. They might ask you to do Kegel exercises to strengthen your pelvic floor, to take antidiarrheal. But if it really gets bothersome, there's something called sacral nerve stimulation that they can put in a small pacemaker into your sacral nerves, linked to your sacral nerves. It's a very, very thin, like a credit card, a very, very small. We have done it in a few patients. And they put a temporary one to see whether they can improve the tone of your rectal muscle. And if it works, they put a permanent one. Hopefully, none of you ever need it, but there are treatments available. And if you do have significant incontinence, you should be talking to your rheumatologist and gastroenterologist because there are treatments available. And finally, there's something called primary biliary cirrhosis. So primary biliary cirrhosis usually happens later in the disease where you have autoimmune hepatitis. So it's not cirrhosis of the liver due to drinking alcohol, it's due to your autoimmune disease. And what you develop after years is a lot of itching that happens and your liver function tests become abnormal. So there's again treatment available for that, but something to keep in mind as you think about your disease. So what we do at Michigan is we have put it electronically. Every patient before they come to us, they complete this questionnaire that I developed. It's a 34-item questionnaire that we ask about the different part of gut involvement: food pipe, stomach, diarrhea, constipation, fecal solage, and the impact it has on emotional and social functioning. And this is a snapshot what we do. I'll quickly, because we have 20 to 30 minutes to see a new follow-up patient. I have to talk about the skin, I have to talk about ILD, I have to look at the forced vital capacity, I have to talk about echocardiogram, I have to talk about musculoskeletal. Somewhere in there, I have to make sure I address the GI involvement. And this is a very simple one. If somebody has reflux, high scores on reflux, what education I can give. If they have a lot of distension, bloating with diarrhea, I'm thinking about SIBO and trial of antibiotics. Constipation, fecal solage, or if they have out of proportion emotional symptoms with really no symptoms, you start thinking about fibromyalgia of the gut. So we tend to address that, and every patient, we have thousands and thousands of data that we have collected in people, but it really helps me to focus when the limited time I have in the clinic and say, okay, these are the different things that we will try. And these are pretty old. There are 2 articles that we wrote a while ago that probably should be updated for Scleroderma, National Scleroderma Foundation. This is, I think, about 10 years ago when we wrote this. Gut involvement in scleroderma and eating well with scleroderma with Linda Kaminsky, who's a nutritionist at Michigan, but also a person with scleroderma. So in conclusion, GI involvement is common. Sleep at an angle if you're not doing that, and don't raise the whole bed, only the head side of the bed. Be proactive. Ask your doctor. If you have rectal incontinence, tell the doctor. There are a lot of things that we can offer and do for you. There's absolutely no reason to continue to suffer from it. And with this, I want to tell you the reason part of it is that we have a partnership with the Scleroderma Foundation of California and Greater Chicago. I'm the president of something called Friends of World Scleroderma Foundation. World Scleroderma Foundation was founded in Italy by Dr. Marco Mattucci, and our goal is to promote the vision of education, research, and also to teach the primary care doctors for early diagnosis of scleroderma. Most of you, it took a while for diagnosis of scleroderma. You had symptoms, you went to primary care says it's all in your head, go back home, then you came back, and then all this starts. So we are trying very hard to teach the primary care doctors to early diagnosis. So we have put together a CME program. CME means that the doctors will listen to it and they will get certain credit to keep their license and accreditation, called Early Detection and Diagnosis of Scleroderma. They should be available online soon, so you can see that we have Tina Berger, who's part of Scleroderma Foundation of California, and Beverly Townsley, one of my patients at Michigan. Dr. Clements and Kafaja talking about scleroderma, what to think about differential diagnosis. Dr. Varga, who you all love, he's talking about what causes scleroderma. In medical term, we call it pathogenesis. Susan Murphy, she's a PhD. Susan has been a wonderful partner, and Stephanie should invite Susan next time. She's an occupational therapist, and we are doing a lot of studies with her on non-pharmacological management of people with scleroderma, especially hand contractures. So we have a very large trial that just got funded where we are doing a tele-rehab. So if you have early scleroderma with upper limb contractures, you can enroll into a clinical trial with on a Zoom. An occupational therapist will work with you on regular basis and see whether we can promote the function of your upper limbs. And then Dr. Dan First, who will be talking about the treatments of systemic sclerosis. So hopefully this partnership will lead to important insights and important education, not just for the primary care doctors, but also for the rheumatologists. Thank you very much. And I should have said something. I'm not a gastroenterologist, just to let you know. I should have started. I'm a rheumatologist who directs the scleroderma program at University of Michigan. But I had to become a gastroenterologist because I was seeing, we see 2,000 patients at Michigan, so one way or the other I have to treat them, so I learned a lot. But I don't do endoscopies or anything like that, so I just want to clarify. Questions? Yes?
Have you noticed a reversal, so to say, and any people to change their diet and what kind of eliminated dairy?
That's a great question. So the question is, reversal defined by improvement in symptoms? Yes. One slide I should add, and it occurs to me every time I give this talk, is that 10% of patients with scleroderma may have celiac disease. Do you know what a celiac disease is? You have allergy to wheat. So when you take, you got it, say. So here 5% of, 5, just doing the mathematics here. So celiac disease are patients who are gluten insensitive and they have allergy to that. So, if you're feeling that, your doctor should test the blood work to look for antibodies to the gluten. Yes, some people change their diet completely. Some people go on a vegan diet, some people, and it's okay to do that if you do that, but make sure you are working with the nutritionist to supplement the nutritions that you are not getting now by stopping egg, milk, meat, and all the things you're doing. It doesn't reverse the short-circuiting of the electric system in your gut. It's not going to prevent that part that we know of. But your symptoms will improve, and if they improve, that is absolutely fine. Any other questions? Oh.
So the people that have celiac and have to take medications and do all the testing, everything for scleroderma, I've noticed it's been really hard to do because you're switching medications and trying new things, and my question is if there's certain testing that requires you to eat or have certain food for the testing, is there substitutions for that?
Yeah, that's a very specific question. I don't know the answer to that. Are you talking about testing for the gut? What kind of testing are you talking?
Any testing, any scleroderma testing.
Yeah.
Because I know before I became celiac, I did the barium swallow.
Uh-huh.
And they put the tracer in the eggs.
Mm-hmm.
So I was just wondering, when they do testing, is there other, can the food be substituted for something else?
Yeah, I'm sure it can be substituted, but eggs are fine in celiac disease, aren't they? Or you can't take eggs if you have celiac disease, I don't know.
It depends on how severe.
Okay.
I can tolerate it.
Okay. Yeah, I don't know. I think that would be a question for really the people who do the testing. I'm sure there are other food that are available, and hopefully you don't need to do barium swallow on regular basis to be able to be worried about that.
It's an off-the-wall question, but you hit on several topics that she deals with. The most important one to us was the damage to the teeth. And I don't know if you'll be able to answer this question or not, but we found dentists who specialize in medical billing for teeth damage so that you can cover it under medical versus dental. So we did that, And then our insurance company, I'm not going to talk too much about insurance companies, but they sent us, well, we can do that in network, so we'll send you to our people. And then they denied it because they need letters of medical necessity. So what I'm getting at is you sound like you're in educating a lot of different doctors. Are you aware of any places or resources for scleroderma patients to show medical necessity for dental issues?
Well, I mean, so the most common, one of the common causes of weight loss is that if you can't eat properly. You know, you need teeth to be able to eat and, you know, chew your food appropriately. So I need to understand a little bit more. We work with the National Foundation, works with Dr. David Leder, who's a dentist. Stephanie, you know him well, right? David is a dentist at Tufts who has been a vocal, absolutely a billion champion for people with scleroderma, especially with the teeth involvement. And some of the slides I showed you earlier on belong to the work that he has done. But I'm not sure why it is not a medical necessity. If somebody is losing weight, I'm not sure why would a doctor say it is not a medical necessity if you're losing your teeth.
Yeah, because they're starting to, after 20-something years of me taking care of them. And that was the first thing to show was my acid reflux. And it took them 3 years to diagnose me with scleroderma, but that wasn't until I got orthodontics.
Okay.
But every doctor I went to told me there was nothing wrong with me. It was just stuff draining down into my stomach. It was upsetting my stomach.
Yeah. So, you know, this is what we are trying to change with the CME program.
Yeah.
We want to educate the primary care doctors. Scleroderma is a rare disease. That's just the reality. There are 150, 200,000 people with scleroderma. The population of US now is 350 million. So you can do the mathematics. I don't blame the primary care doctors. They are taking care of everything. Rather than blaming them, our job here should be to educate them. And I think the more education we do, the more successful we will be. And I think the partnership that the Friends has with the Chicago and the California chapter and your donations and the research we do and the outreach we do is important and critical for us to do together. Yes?
I actually have 2 questions.
No, you can only ask one.
The first one, you had mentioned that sometimes you go to the ER with chest pains and it turns out to be acid reflux. So is it possible to have acid reflux, but you do not feel any of the symptoms of acid reflux?
It is not uncommon. It is actually not uncommon. The two most common reasons if the chest pain is not MI is panic attacks and acid reflux. And the classical acid reflux would be that you will have behind your sternum or the bone here, you'll have a lot of acidity and chest pain that happens beyond it. And the reason is sometimes acid can cause spasm of your food pipe. And that spasm causes significant chest pain. Actually, when I used to have bad reflux, I used to get them. It is really, really bad chest pain, but it is limited to behind your sternum. It is not radiating down. A typical heart attack would radiate down to the left hand and things like that. And there's no way to do that in the ER. They look for your cardiac enzymes, they do a EKG, and then they give you something called GI cocktail. There's no alcohol in it. It's a cocktail of antacids and anesthetic to kind of calm it down, and the symptoms are relieved like this. And that's how they know it is probably related to acid reflux.
And my second question was, when you were speaking of GAVE, I'm not sure if I heard right, you mentioned that it slows down?
So GAVE is watermelon stomach, and it doesn't slow down. It's usually earlier in the disease, like I said, and to treat it, if you have watermelon stomach, a gastroenterologist will go there with laser, argon laser, and it will just destroy the areas that are bleeding. And that's how they treat it.
What did you say is in the GI cocktail?
Or GI cocktail has anesthetic like Novocaine or lidocaine, just to coat your food pipe, and it has antacids. And it might have, Pepsid. I don't know what all is included, but it includes 3-4 different things in the GI cocktail. Any other questions? Okay, thank you.